All right, future clinicians, welcome. Today, we're going to do a deep dive into a real workhorse, one of the most powerful and versatile drugs you'll ever use, dexamethasone.
So here's how we're going to tackle this. We'll go through the basics, how it works in the body, its uses, the warnings, and some key practice points. We'll finish with a classic clinical pearl. It's basically like breaking down a drug monograph, so you'll have a really solid framework. Let's jump right in.
Okay, first things first, what is dexamethasone really? Where does this powerhouse steroid fit into the grand scheme of things? So here's the deal. Dexamethasone is a potent synthetic glucocorticoid. That's a mouthful, but what it really means is that it's a man-made version of cortisol, which is that natural hormone our adrenal glands pump out to fight inflammation. The key difference? Dexamethasone is way, way more powerful. It's like taking our body's own system and turning it up to 11. All right, now let's get into the nitty-gritty. How does this thing actually work on a molecular level? And once it's in the body, where does it go? We're talking about the classic ADME framework here: absorption, distribution, metabolism, and excretion. Okay, so check this out. It's actually a pretty cool process. Because dexamethasone is lipophilic, which just means fat-loving, it can slip right through the cell membrane like it has a VIP pass. Once inside, it finds its dance partner, the glucocorticoid receptor. They bind together, and this new power couple travels right into the cell's nucleus, the main control center. There, it gets right to work on the DNA, basically flipping switches on our genes to tell them, hey, stop making all those inflammatory chemicals. It's literally shutting down inflammation at the genetic source. Super powerful stuff.
Now for absorption. One of the best things about dexamethasone is its flexibility. You can give it orally, and it absorbs really well. But you can also give it IV, IM, as a topical cream, even as an inhaler. This is huge because it means we can tailor the delivery to the problem. Need a fast body-wide effect for a patient in shock? Go IV. Just need to treat a skin rash? A topical cream works great. It's all about getting the drug right where it needs to be.
Okay, next up is distribution. Once it's in the bloodstream, a lot of dexamethasone latches onto plasma proteins. You can think of this like a drug reservoir. The part that's bound up is just hanging out, inactive for now. It's the little bit of free, unbound drug that's the active part. It's what can actually leave the bloodstream, get into the cells, and work its magic. As that free drug gets used up, the reservoir releases a little more, which helps maintain a nice, steady effect over time.
And now for metabolism. Like so many drugs, the liver is the main processing plant. It uses the famous cytochrome P450 system to break dexamethasone down, specifically an enzyme called CYP384. Now, you have to remember that, because a ton of other drugs use that same pathway. This creates a huge potential for drug-drug interactions, so you always have to be thinking about what else your patient is taking. The liver's job is basically to make the drug inactive and easy for the kidneys to get rid of. And last but not least, excretion. This part's pretty straightforward. The kidneys do the final cleanup job. They filter out all those broken down metabolites from the blood and send them out in the urine. And just like that, the drug's journey is complete. Okay, so we've got the science down, how it works, how it moves through the body. Now let's get practical. When do we actually use this stuff? And just as importantly, when should we be really, really careful? This is where the rubber meets the road. And wow, look at this list. The range of uses is just incredible. I mean, we're talking about everything from reducing life-threatening swelling in the brain to calming a severe allergic reaction or an asthma attack. We use it to fight autoimmune diseases like rheumatoid arthritis, where the body's basically attacking itself. It's even a key player in some cancer therapies and helps prevent organ transplant rejection. It really shows you just how powerful suppressing inflammation and the immune system can be. Pay close attention here because this is one of the most important slides. On the left, you've got your absolute do not use situations. These are the hard stops. For example, if a patient has a widespread fungal infection, giving them a drug that nukes their immune system would be an absolute disaster. Then on the right, these are your use with caution groups. Think of them as yellow flags. Patients with diabetes, heart failure, hypertension, you have to think very carefully about the risks versus the benefits. In these patients, you're walking a tightrope.
Okay, so we've talked about how powerful this drug is. But with great power comes a whole list of potential side effects, especially when you're using it long-term. Remember, there's no free lunch in pharmacology. There's always a price to pay for this kind of potency.
And this quote really nails the central dilemma of corticosteroids. It says that because they reduce the body's ability to fight infection, they're typically used for short-term therapy. That's the core trade-off right there. The exact thing that makes them so good at their job, suppressing the immune system, is also what makes them risky. You get fantastic anti-inflammatory effects, but you leave your patient more vulnerable to getting sick. This table breaks down that price of potency by body system. So with the immune system, you get a higher risk of infection. That's a given. In the endocrine system, you can see high blood sugar and even adrenal suppression, where your body's own steroid production facility shuts down. Musculoskeletal, we're talking about an increased risk for osteoporosis and muscle wasting over time. Even the central nervous system can be affected, causing mood changes or insomnia. And then there are the visible changes. Long-term use can lead to something called etiogenic Cushing syndrome, which gives you that classic moon face or a buffalo hump from fat redistribution. Okay, let's bring all this information back to the bedside. What do you, as the clinician, actually need to do and say? Let's talk about the practical stuff. So I want you to pause for a second and think about this. Based on everything we've just talked about, all those side effects and risks, what are your priority assessments? What are the absolute must-check things before and after you give this drug? All right, here's your checklist. Number 1, you have to be an infection detective. Any little sign, like a fever or a sore throat, is a huge red flag. Number 2, check blood glucose. Steroids can send blood sugar soaring, especially in patients with diabetes. Number 3, assess their fluid balance and blood pressure. These drugs can make the body hang on to salt and water, which can cause swelling and high blood pressure. And number 4, if they're on it long term, you're on the lookout for those classic physical signs of Cushing syndrome. Now, what about dosing? The truth is, it's all over the map. It completely depends on what you're treating. For something super serious like cerebral edema, you might start with a big 10 milligram IV dose and then follow it with smaller doses every 6 hours. But listen, the main takeaway here isn't to memorize this one dose. It's to know that you always, and I mean always, double-check your dose in an official reference. And that goes triple for kids, where dosing is incredibly specific and can be a real minefield if you're not careful. Okay, this is what you need your patient to be able to say back to you. The teach-back method is crucial for safety. First, they need to know to call you immediately if they have any signs of getting sick, like a fever. Second, if they have diabetes, they have to understand why they need to check their blood sugar more often. And number 3, this is the big one, the golden rule, never stop this medication suddenly. You have to explain that we will have a specific plan to wean them off it slowly in safety because stopping cold turkey can be incredibly dangerous. All right, let's wrap up with a little something extra. This is your clinical pearl, a high-yield fact that's perfect for exams and just a cool thing to know in practice. So get this. We can actually use dexamethasone not just as a treatment, but as a diagnostic test. It's called the dexamethasone suppression test. Here's how it works. We use the drug's ability to talk to the brain and tell the adrenal glands to chill out and stop making cortisol. In a healthy person, you give them dexamethasone and their cortisol levels plummet. But if the cortisol levels stay high, that's a huge clue that something's wrong. It often means there's a tumor somewhere that's just pumping out cortisol on its own, ignoring the brain's signals. And that's how we help diagnose conditions like Cushing syndrome. Pretty clever, right? So, after all that, what's the one thing you absolutely must burn into your brain about giving steroids? If you remember nothing else, remember this. You must taper the dose. Never, ever stop it suddenly. Abruptly stopping can throw a patient into a life-threatening adrenal crisis. Their body has forgotten how to make its own cortisol. This can lead to a total collapse, severe low blood pressure, and shock. Always, always taper. Remember that, and you'll keep your patients safe.